Okay, well, welcome everyone to our On the Pulse series. So glad you chose to make time to spend this noon hour with us. I am Chris Fortman. I'm the CEO of the Minneapolis Heart Institute Foundation. And before we get on to our keynote speaker for the day, I would just like to provide you with a little feedback about the Minneapolis Heart Institute Foundation. We are an independent nonprofit organization, and we have many research and education staff members who are solely committed to lifting up and moving forward physician research, both in physician-initiated research and industry-sponsored research. None of this would be possible without a fabulous partnership with the Minneapolis Heart Institute that sits at the flagship hospital within the Allina Health System at Abbott Northwestern Hospital. You can see in the visual that research and education are at the top of that circle. Our mission is to improve cardiovascular health through innovative research and education, all to improve clinical care. Here you can see some pictures which really tell it all. You can see the happy faces of our researchers. Many times we are able to do first in human and very important ground shifting research. We have over 200 active studies, about half of those in physician-initiated research and half in industry-sponsored. On the right side, you'll see one of our favorite pictures, and that is of our research interns that we have about 200 alum, many of them currently practicing medicine, and all of them very interested and committed to research and improving care through research. Here are some more pictures of community education offerings, very happy research patients who have participated in our programs and are now ambassadors of the important work happening here. And all those folks in red are some of our team members celebrating Go Red. And we are committed to disseminating our research not only locally, but nationally and globally. We depend on the community members who helped us found this foundation about 38 years ago. None of this work would be possible without the support and belief of the community. So thank you for helping us start this and continue this important work. If you're interested in learning more about the work that's happening at the Minneapolis Heart Institute Foundation and specifically about some of the research happening surrounded by COVID-19, please do visit our website. You can see some of the recent press releases and articles there and some perspective from our physicians. So we welcome you to join the website and learn more there. And it is my pleasure now to introduce Scott Sharkey. Dr. Sharkey is the Chief Medical Officer and President of the Foundation, researcher, friend, mentor, and he is going to introduce our keynote today. Thank you.
Hello, everyone, and I hope you all continue to be well, and thanks so much for taking the time to be with us. I have the great privilege of introducing our speaker. It's my friend and colleague, Dr. John Zakaib. John is an electrophysiologist, and we recruited John from Virginia, Virginia the state. I have to distinguish that in this Minnesota here, from Virginia about 3 years ago because of his reputation for patient care and his intellect. So we're really happy to have John. Let me just tell you a few things about him before he comes up here. John received his medical degree from the Virginia Commonwealth School of Medicine and his cardiovascular training and electrophysiology training at the Cleveland Clinic. John and his family live in St. Paul. And John enjoys sailing. In fact, he was sharing with me before this introduction that he once raced his sailboat from Massachusetts all the way to Bermuda. And he's already been up to Lake Superior to check that out. One other thing to tell you about John is not only is he a cardiologist and electrophysiologist, but he's also a cardiac patient. When he was at the Cleveland Clinic as a chief fellow, he developed some heart-related symptoms and was eventually diagnosed with a tumor on his heart, and for which he underwent surgery to remove it, obviously successfully. We're thankful for that. And John distinguishes himself by being one of the few of my partners that has presented his own case at our grand rounds on Monday morning. So John, welcome and thank you so much for taking the time here.
Thank you so much, Scott, for that kind introduction. And Chris, thank you, especially in all the foundation for the opportunity to be with you today. I'll take just one moment of your time to point out that Scott is always smiling. And I think in these times, I couldn't say anything greater than a smile is such a powerful signal of hope and optimism. So thank you for your introduction and thanks for smiling, Scott. All right, I'm going to press the button and try to get things started. There we go, that's me. I was younger then. Okay, so my charge is to speak about arrhythmia management in the era of COVID-19, which is a fascinating topic. We got a lot to cover about what's an arrhythmia, what's arrhythmia management, and how does COVID-19 fit in, and we'll do that. But first, I did want to reiterate how important it is that we take care of ourselves. And you can see I've got all my protective equipment on and my radiation glasses that have my bifocals and my splash-proof gear here, and you name it. But we also need to take care of our spirit and take care of each other. And so I put a few things here on my list, and of course my wife would add drink water, and my my infectious disease colleagues would say wash your hands. But I figure those are fairly self-explanatory. So I think we all need to get some exercise, and we need to breathe fresh air. We need to be good to each other. Sleep enough, but not too much. Be creative. Find the humor in everyday living, and keep smiling, even behind the mask. So to stimulate our intellect, I've created this map of the human heart. And I took out all of the small print because I was asked not to include a lot of small words or statistics because they don't show up on Zoom very well. And I think that's right. It's always kind of blurry. So you can print this out at home and you can spend an afternoon on the internet trying to figure out what all those little lines point to. But the important parts of the anatomy here, some are on the outside, and we'll be looking at these veins that run on the outside of the heart at some point a little bit later. And then some are on the inside, and there's 4 chambers. You know, the heart is a 4-chambered pump with 2 upper chambers that are designed to prime the 2 main pumping chambers. I've got the little laser on the lower pumping chambers called the ventricles, and 4 valves. And so 4 chambers and 4 valves. And it's like a gasoline engine. If it's not timed properly and the chambers don't beat in sequence, it's not very efficient, and we run into trouble as we go along if we don't have our timing right. And so what I do in electrophysiology is all about the timing of contraction of the different chambers. And when those timing cycles are out of kilter, we call that an arrhythmia. So if you ask yourself, well, how does the heart work from an electrical standpoint? You know, it's a hydrodynamic flow pump, and it's got those 2 upper chambers, 2 lower chambers, and we can record the electrical control of that pump using the EKG, which is this surface tracing. And when we're working inside the heart with catheters and measuring the electrical activity inside the heart, we have these what we call intracardiac tracings. But I've got this picture here. It really shows you the anatomy of the electrical system of the heart, which is critical to the things that I do. But we'll revisit this picture as we go along, and maybe you'll get a little bit better understanding of how the electrical system of the heart functions. But ultimately, the signal to beat comes from the sinus node, which is this little yellow structure up here in the top left corner in the right atrium. And then that signal is propagated through this complex electrical system called the His-Purkinje system. down to activate the ventricles in synchrony and with incredible elegance and efficiency. And so this slide shows you a functional MRI of the mechanical activation of the heart under exquisite electrical control. And you see that beautiful organic function of the two upper chambers squeezing, filling the two lower chambers, and then the two lower chambers pumping in synchrony. And you get profound efficiency. The heart here, I've got a couple of little statistics. At rest, the heart pumps 5 to 6 liters of blood per minute. That's a little bit more than 5 to 6 quarts of blood. You may remember from your metric system. That's 100 milliliters per beat, but under conditions of extreme exercise, you look at Michael Phelps, his heart can pump 32 liters of blood per minute when he's swimming down the pool. And so the heart rate and the contractility, the pumping function is all dynamic with the demands of the body. Okay, so that's normal rhythm and normal function. But what's a cardiac arrhythmia? Well, it can be an abnormal sequence of activation of those different heart chambers. It can be an abnormal sequence of beats if they are occurring slightly differently. It can be perceived and cause symptoms. It can be imperceptible. It can be harmless, or it can portend significant risk, or it can portend things to come that are potentially ominous. So what are things that cause changes in the heart rhythm or arrhythmias? Well, adrenaline certainly can be beneficial in the setting of exercise, or it can be abnormal in the setting of critical illness, especially when we talk about COVID-19. There are drugs that can affect the heart rhythm, either intentionally, antiarrhythmic drugs, or unintentionally, like antibiotics that you may have heard of, or other medications. Electrolyte imbalances, especially under critical illness with changes in electrolytes, potassium and calcium, hypothermia, hyperthermia, fever. I mean, these are all, and then some complex things that can cause changes in the heart rhythm, and aging. And the only example of aging I could think of was getting older. So when we talk about arrhythmia management, what does that mean? Well, we do things as physicians in the hospital and in the clinic to characterize and to understand the clinical impact of arrhythmias, as well as the symptoms and the patient and the impact on patients' lives. And so we provide inpatient and outpatient care. We have devices like pacemakers and defibrillators that we can manage remotely, which is very convenient in the setting of social distancing, where we can gather data from a patient's implantable device from their home and get answers to questions that may arise, and try to manage things as we go along. We do electrical shocks. That's my kid's favorite part of my job, when I get to electrocute somebody, but of course we do it under sedation, so it's very refreshing for the patient also. Device implants and testing. We do catheter ablation to try to fix arrhythmia problems and modify the electrical activation of the heart. We use medical therapies to try to control the heart rhythm. And like all physicians in this day and age, we're constantly advising people not to inject disinfectant for whatever reason that's come up. So what about the pandemic? How have things changed? Well, amazingly, we have a lot of patients in cardiology and in heart rhythm that would otherwise be high risk for an adverse outcome if they develop COVID-19. So it becomes very difficult to manage their cardiovascular problems when you can't see them in person. And so we've transitioned a lot of our outpatient management to what we call virtual visits. We used to call that a phone call. Now it's a virtual visit. And we're, arranging for video conferencing and other things that allow us to better, relate to our patients when we try to manage their heart rhythm and their cardiovascular concerns from far away. We have pushed off some elective procedures. So patients who need a pacemaker for one reason or another, or who need an ablation or need us to do something for them, some of them have been put off to some degree because we can't have them in the hospital in the setting of this surge of the critically ill. And sometimes that's to the detriment of the patient. And so as we see patients who are having trouble and resulting in their visit to an emergency department, it's time for us to bring them in and get their procedure done to keep them out of the ER. So we're using more aggressive therapies. And in fact, sometimes we use a medicine that you might think is more aggressive than we otherwise might normally use to manage a problem. But in terms of our ability to keep people safe and keep people out of the healthcare system, we're using more aggressive therapies up front, and then we'll transition those therapies to something maybe more reasonable for the long term after the first wave subsides. And inpatient procedures that need to be done, or emergency procedures, we're doing in the hospital every day. But they're encumbered by the need to protect ourselves and our staff and our patients from risk of the COVID-19 infection. And so we have all this protective equipment that you've heard so much about to try to protect ourselves as we perform these procedures. So as I tried to put these slides together, the data keep changing. And so I just finally committed on Sunday and said, I'm going to use Sunday's data, and yes, it'll be old. And really it brings up the point that never before in the history of epidemiology or of medicine has surveillance, disease surveillance, and data collection and analysis and public health response kept pace with a pandemic. I mean, the last time this happened, there was no, there was no way to characterize it or quantify it in real time, and now we're able to do that. And so what we're seeing day to day as our case numbers change and as our hospitalizations change, and unfortunately as our mortality changes, we're able to keep up with it and characterize it and see what's happening. And as you see these curves, these are Minnesota Department of Health data for this past up through Sunday. What you see is rising numbers of cases and rising numbers of hospitalizations and increasing healthcare utilization. And that represents a gathering storm, and we know that. And so as we prepare to manage an influx of inpatients and an influx of the critically ill, I would say that this is what I would call a gathering storm. I mean, you see on the horizon what's coming, and you have however much time to prepare, and then we're going to be in it. And so that's where we're headed. So my small part of that is managing arrhythmias. And so the question comes, does COVID-19 infection cause arrhythmias? Well, the virus is called the SARS-CoV-2 virus, and the infection is called COVID-19. Well, COVID-19 causes a severe respiratory infection. It can cause some other things, and writing slides last week is different than writing slides this week, and so now we know about a vasculitis and large vessel thrombosis with clots and strokes, even in young people, and paresthesias and neurologic phenomena that we didn't know about last week that we know about this week. So our understanding of this is evolving, but it can cause such stress on the system that there are other things that can result. The adult respiratory distress syndrome, called ARDS, requires intensive care unit management, and mechanical ventilation. And that doesn't happen in everyone, but what we see is that it happens in 4 to 5% of patients who develop the infection. And that's ultimately such a large number that we have an influx of patients in the ICU. It requires mechanical ventilation for an extended period of time while the lungs recover, and that can result in severe critical illness. And the stress of that illness can result in cardiovascular problems that might otherwise not have been impending, but certainly that people had risk for, and that's heart attack and stroke, among other things. So where do arrhythmias fit in? Well, when you put someone under critical stress and they have organ dysfunction with low oxygen levels and kidney dysfunction with changes in electrolyte levels, they can develop the underlying substrate that results in those arrhythmias we talked about at the beginning. And so there is some secondary cause of arrhythmias, and commonly it's atrial fibrillation, which is an arrhythmia of extreme stress, ventricular tachycardia, which can be an arrhythmia that occurs in the setting of other structural heart disease or coronary disease or prior heart attack, and cardiac arrest, which can happen under any of these circumstances in the setting of critical illness. So there's that in the inpatient setting, and then the outpatients, unfortunately, we've seen a rise in out-of-hospital cardiac arrest. And that phenomenon is complex because there's this concern that patients who are having shortness of breath at home and are being advised, don't come to the hospital if you're short of breath unless you're really sick, because you probably have this virus or you have risk of getting the virus being in the hospital. And so people are staying home. And we've seen in Italy and we've seen in New York and other places where people have stayed home for symptoms or problems that they thought might be attributable to this virus that likely were attributable to a heart attack that was occurring. And so then they develop the downstream effects of an unmanaged heart attack they stayed home for, and that can be the consequence of staying home for the wrong reasons. So I would encourage people, if you have symptoms and you need to be evaluated, just come and do it, and we'll protect each other and protect you and try to make sure that everyone stays safe. A final point is that some of the drugs that have been used to treat COVID-19 infection may be putting people at risk for other rhythm problems, and I'll talk about that here with hydroxychloroquine. So the hydroxychloroquine story goes back many, many years. It was originally an anti-malarial drug, but it turned out to have some properties that were immune modulating properties. And so really it's been used more in this country to manage lupus and rheumatoid arthritis than malaria. We don't really have malaria in this country. But there were reports that it might have efficacy against COVID-19, and those anecdotes were based on some really probably shaky and thin data and observations. And ultimately, there was widespread use of a drug that subsequently was shown not to have a real benefit. As a result of a variety of factors, but the presidential endorsement being a significant one, there was a lot of demand for hydroxychloroquine. And as a result, we got the adverse effects of mass utilization of a drug off-label. And subsequently, the science showed we didn't get the benefit we were trying to obtain. So there was a famous president whom half the people loved and half the people hated, whose comments have bearing on this. And that is, don't believe everything you read on the internet just because there's a picture with a quote next to it. So I think it's very important that we think about whether the drugs that we're using are going to help us And is there a possibility that they're going to hurt us? It turns out that the adverse effect of hydroxychloroquine is to prolong the electrical recovery of the heart muscle after each beat. And when that happens, there is an increased vulnerability of that heart muscle to become disorganized, and the result of that can be catastrophic. So when you have a critically ill patient with respiratory failure and low oxygen levels and abnormal electrolytes, and then you prolong the electrical recovery of the heart muscle, you can develop a problem, especially in combination with other drugs that also potentiate this, in this case, azithromycin, with unstable electrical storm. The underlying substrate when a person has this problem is called the prolongation or prolonged QT interval, and the QT interval is really the time between the electrical activation of the heart, right here at the beginning of onset of electrical activation of the heart muscle, to this delayed, prolonged recovery of the muscle. And that's called the prolongation of the QT interval. This is profoundly prolonged in this example. And so when a physician sees that, they're supposed to know that's not a good sign. And the result of that can be catastrophic. You can see here's our normal electrical activation, but there's an extra beat that's hitting right after the normal beat. And then it happens again, here's a normal beat. The same extra beat hits just at the right moment during that prolonged and disorganized recovery period after electrical activation. And suddenly the heart muscle has become disorganized, firing at more than 300 beats per minute in a very inefficient way, doesn't pump any blood, and the person suffers a cardiac arrest. So unfortunately, this is where we landed with some patients with using a therapy like hydroxychloroquine that was unproven but was known to have risk. And that is the reason why we can't adopt an attitude in these types of situations where we say, well, it might help, and what do you have to lose? We do have things to lose. Here's another photograph I took. This is out in the Atlantic Ocean. And sometimes you see a storm and it's not affecting you, and so it can be magnificent. It can be beautiful when you're just far enough from the fury of it that it can seem peaceful. Take a picture. All right, I briefly have a story to share of one of our patients who suffered just a profound presentation with COVID-19 and how things unfolded and what we did about it. And then maybe we could talk a little bit about other things, and I'll be happy to answer questions. But this just was, I mean, this has just been unfolding for the past 2 weeks, and so I thought we'll just briefly do. So our patient is a 58-year-old gentleman who was previously healthy, and he contracted COVID-19 in March. He had fever and chills and cough and shortness of breath, and he went to the doctor and they tested him for influenza, and he was positive. So they sent him home and said, you got the flu, stay well hydrated, take it easy. And he did go home, but he continued to get worse and worse, and eventually came back to the hospital profoundly short of breath. His oxygen level was severely compromised, and he had a severe COVID-19 infection. His COVID test was positive, and it was recognized, well, he had a co-infection. He was brought into the hospital, put on a ventilator, and he was previously healthy. So this is one of those patients that you weren't expecting to see a profound catastrophic illness, but that's what he had. So he got on the ventilator and was treated with oxygen and all the things that we do to try to help support people through this organ failure until they can recover. He had a difficult course, but after 7 or 8 days on the ventilator, he recovered and he came off the ventilator, and he was getting better in isolation over the next couple of days when he had a cardiac arrest. So he was resuscitated by really a heroic team that did what everything they had to do to help him. and he survived that, but he had severe dysfunction of his heart and electrical system damage after that. So he was seen by our inpatient electrophysiology team, and they recognized that he had something called left bundle branch block, which is an electrical phenomenon of the lower electrical system of the heart, where the fiber that activates the bulk of the muscle in the heart, the left ventricle, is non-functional. And so the signal that goes from his upper chambers to his lower chambers activates the right ventricle, but it eventually makes it around to the left ventricle by a very slow process that is disorganized. And as a result of that, the dyssynchrony that's introduced in this problem of activation of the heart muscle results in severe dysfunction of the heart. And his heart function was estimated at between 10 and 20%. So the heart was trying to beat, but really just wiggling because it was being activated improperly. So the team saw this and said, hey, we need to offer him a device to prevent a death from another cardiac arrest. It certainly has high risk for that. But we also have to put wires in both the right and left ventricle to resynchronize the heart and try to improve the heart function that way. So just to show you the difference in what dyssynchrony can cause, this is the original model or rendering of the heart muscle under normal conditions, and you can see the activation pattern of the heart right here. It takes a very short period of time to activate all of this muscle mass. This is the left ventricle right here. Very organic and elegant and extremely efficient. This is left bundle branch block, where the electrical pattern of activation is so slurred and delayed that it takes, instead of 80 milliseconds, which is normal, 200 milliseconds to activate his left ventricle. And you can see here, the left ventricle is really kind of wiggling, and there's just this washing machine effect of blood roiling around in the ventricle, and it's not being pumped out briskly. And so when we say under normal circumstances, the heart pumps out 60% of its contents with every beat. In his case, he's barely pumping out any blood with each beat, and so he has to beat much faster, and it's really an unstable and untenable scenario. So he had persistently positive COVID testing, so we had to use all our full protective gear and mechanical ventilation for the procedure, and we brought him to the lab and got to work to implant these wires to try to resynchronize the heart. And I'm just going to show you a few pictures because it's kind of dramatic how he did. But I tried to put the wires into the left ventricle using the veins that run on the outside of the heart, which is our standard approach. And that works about 95% of the time. In 5% of the cases, the person doesn't have a vein that you can use to place a lead, or you place a lead in the appropriate location and then there's scar under that location. And so your electrical stimulus doesn't achieve mechanical contraction. So there's some technical issues there. What I've done here is put pictures of the video X-ray images that I can see during the procedure in two different views. And these cartoons show you the view of the heart that you're looking at. On the right, you're sort of looking at the side view of the heart through the chest wall. And I'm sorry, that's on the left. On the right here, you've got the end-on view, and the heart's coming straight at you, just like a football. And these injections are injections into the vein that runs on the outside of the heart called the coronary sinus. And what you see, especially in this right-sided view, is there's no vein over there on the sidewall of the heart to put a lead in. There's just this high vein up here. Not ideal. And so I did attempt to put a lead in that upper location. You can see the heart beating here. This is a pacing lead. It's got 4 electrodes on it, and it's stuck out in that vein up there. But the lead would not stay in that vein. And we spent several hours working on ways of trying to get a lead to stay with different leads and different fixation. And ultimately, that was not going to work. And so after a few hours of that, we had to transition to a different approach. And the approach that I took in this case was one that I've been working on here at the Heart Institute for the past 2 years. And that is something that's being adopted slowly worldwide, in which we're able to implant a specialized pacing wire directly into the person's conduction system itself. And even in the setting where the conduction system has failed to work, and in some patients I've implanted where the left bundle has not functioned properly for 30 or 40 years, we can implant a lead directly into that location. We can achieve or we can restore the function of the left bundle branch and activate the heart in a very normal way, a normal pattern, thereby resynchronizing it and getting the benefit that we were trying to get with that two-lead system before. So in this case, after failing to implant a left ventricular pacing lead, we were able to implant a lead right here through the septum and into the conduction system itself, and activate the person's native left bundle branch that had not been functional. And so I've got the EKG pattern here. Remember, this took 200 milliseconds to activate before. And now with pacing the left bundle branch, this takes about 125 milliseconds, which is just slightly abnormal. And the result of that can be profound. In his case, he did well with the procedure thereafter, and we got him home in the next few days after that. And he had an echocardiogram on Friday for another reason, and it showed his heart function had come from 10 to 40%, which is a dramatic improvement in 2 weeks. And I talked to him on the phone yesterday, and he told me he had gone for a walk in downtown Minneapolis for an hour over the weekend, and he's doing beautifully, and I would expect him to continue to improve and to recover. So a profound presentation and a dramatic recovery, and really very satisfying to help manage our little part of that with the heart rhythm device implant that I think will really make a big difference in his ability to recover. So in summary, I would say the Heart Institute offers comprehensive arrhythmia care, and we offer it even during a crisis if necessary. And the pandemic itself really provides a variety of challenges for the population and the public health level, down to the individual patient care level. And we've never been in a situation like this before. So we're all sort of making it up as we go along. But never, as I said, has the pace of disease surveillance and data collection and analysis and subsequent public health response kept the pace with the spread of a pandemic like this. So we're really in uncharted territory, but these are historic times. And I think we'll survive and recover as a people and as a culture and as individuals through the coordinated efforts of the population and through individual efforts of each person and the heroism of each person, and through more coffee, which is hard to drink through a mask, by the way. So keep your spirits up and don't forget to smile, even from behind the mask. I'll give you one more storm. This is Cape Hatteras at the Outer Banks. Another storm that could have ruined our day at the beach, but just passed by just offshore, but magnificent. Well, I am so pleased and privileged to be able to speak with you today, and I'd be happy to answer questions about this or about other heart rhythm problems, about ablation or device therapies or storms or coffee, you name it. Thank you so much.
All right, thank you very much, Dr. Zakaib. That was an excellent presentation. We really appreciate your time and expertise. If you could just advance the slide to the next slide, please. And at this point, we are going to, sorry, keep going to the Q&A slide. But at this point,
a million slides here.
Oh, sorry about that. Well, anyway, we're going to open it up for Q&A. To access the Q&A pod, attendees, please drag your cursor to the bottom of the screen, which will pop up a control bar, and then select the Q&A function And it looks like we have a couple questions coming in already. So we can just leave the Q&A slide.
I can get to the end here.
Okay.
If I click really fast.
Sounds good.
This, or the back one. Got it.
All right, so it looks like we have a couple questions in the pod.
Oh, good.
And again, you should now be able to see our Zoom Q&A walkthrough. Just follow those directions and please enter a question or a comment. So Dr. Zakaib, how can people stay up to date with heart rhythm research, especially heart rhythm research relative to COVID-19?
Well, that's a great question. You know, we have some resources for the heart rhythm community through the Heart Rhythm Society. And I would say that that's a good resource. It's weighted more towards medical professionals and really heart rhythm professionals, which is a subspecialty of cardiology. So it may not be the best source of information for lay people, but I think it's a good place to start, and it's a good place to get sort of leading edge ideas about what's going on. And then I think I would just refer to primary sources of news and information, at least healthcare information like WebMD and other reputable sites that can give at least up-to-the-date information and recommendations.
Great, thank you very much. So are patients with AFib more susceptible to getting COVID, or will their care be more complicated?
That is an excellent question. You know, people keep bringing this idea forward. Am I more susceptible to a catastrophic outcome from COVID? Does AFib put me in that high-risk group? And I think, you know, that hasn't been well characterized in terms of who is really at high risk and do atrial arrhythmias really portend high risk. But I would say that patients with atrial arrhythmias are commonly taking cardioactive medications. Some are taking antiarrhythmic medications, which may interact with other medicines that might be used at the time of management of COVID infection. And furthermore, atrial fibrillation patients in particular are also commonly taking anticoagulation. And the prothrombotic story, the possibility that a person will develop clots in veins or even clots in the heart or clots in arteries causing heart attack and stroke, it has not been well elucidated. And so it seems that anticoagulation, whether it's for clots or whether it's for atrial fibrillation, may be protective in the setting of clots forming with COVID-19. So I think it's unclear. I think as long as atrial fibrillation is managed appropriately with proper rate control and anticoagulation, if it's appropriate, then it shouldn't create additional risk. But the broad principle is we should wash our hands, we should social distance and stay away from each other, and try not to get, try not to spread the infection. So it's better never to get this infection than it is to fight it out in the hospital, whether you have atrial fibrillation or not.
Excellent, thank you very much. Could you discuss cryo-maze surgery?
Yes. So a maze procedure is a procedure in which, can I move the slide?
Of course. Yep.
Let me go back a couple of slides. This is a three-dimensional rendering of the left atrium. And this was done with catheters in the setting of a catheter-based ablation procedure for atrial fibrillation. But if you think back to the anatomic rendering of the heart, we saw those two upper chambers that are designed to pump and prime the filling of the lower chambers. In the setting of atrial fibrillation, Here's the atrium. This is a catheter inside the left atrium during fibrillation. And what it's showing you is a profound electrical disarray in the upper chambers of the heart. And here's a three-dimensional rendering of the left atrium in fibrillation. And the sticks that are, it looks like a porcupine having a seizure, what it looks like, but that represents that electrical disarray. It's a way of rendering it. The Mays procedure is a surgical procedure that is commonly offered in conjunction with some other cardiac surgery, whether it's bypass surgery or valve surgery. And what's done is the pulmonary veins, these veins that bring blood flow from the lungs, in green here, this is coming from the right lung, and this big complex in blue is coming from the left lung. Those are actually cut away from the atrium and then sewn back on. And that seems totally counterproductive, but the idea is to create a scar line around in that location that prevents electrical activity from the vein from disturbing the atrial rhythm. And if you can achieve that either by cutting and sewing, which is how the Mays procedure is done, or by doing a catheter ablation, you can achieve which I recorded in this recording back in 2013, and that is that the atrium is in normal rhythm. Here's an atrial beat and then a ventricular beat, and then it is electrically silent. The atrium is electrically silent here until the next beat. Meanwhile, recorded on this catheter out here in one of these pulmonary veins is continuous electrical disarray. And so the point of the Mays procedure was to electrically disconnect the pulmonary veins and then reconnect them by sewing them back together and getting a scar line. The cryo Mays came along in the 1990s, and the idea there was to use a freezing technology to create scar within the left atrium to help keep the atrium organized and prevent it from fibrillating. Essentially the same lesion set as you would have done with a scalpel and needle and suture, but now doing it with a freezing technology that creates essentially freezer burn and scar in those locations. And that procedure can be offered really with a concomitant open heart surgery. But commonly, the surgeons don't use the freezing technology as much as they use a radiofrequency clamp technology that essentially creates the same lesion sets. The freezing technology tends to create less damage and ultimately less scar, and so it was less effective.
Thank you very much. So this attendee writes, in the patient example that you gave, was the cardiac arrest caused by COVID-19?
I think that's a great question. I think the person had suffered a profound critical illness over a period of 8 days. And over that time, they may have developed something called myocarditis, which is a viral inflammatory response of the heart muscle, either because the virus attacked the muscle or because the immune system was so revved up that it attacked the heart muscle. And as a result, the heart muscle was profoundly dysfunctional. The heart function came down from normal, 60%, to 10%, barely functioning. And the electrical system was compromised. And so it seems like all of that happened in the setting of a profound critical illness. And unfortunately, we're seeing some cardiac arrests associated with these COVID-19 infections, but really primarily with the profound critical illness.
Excellent, thank you very much. This attendee writes that they have an Apple Watch and a live core device.
Yes.
What is your view of personal EKG gadgets today?
I wish I had invented it. Those devices, especially the two that you mentioned, turn out to be excellent at recording heart rhythm disturbances and recording normal rhythm. I even have an Alive Core device. I recorded my dog's EKG because it's an excellent device. And people can store their rhythm recordings, and then I ask my patients to store them, print out the ones you want to go over with me, write down what the symptoms were that you had, and then bring them to the office. Because it's very difficult if we're getting a steady stream of recordings emailed to us or dropped off. So those are excellent devices. They can be very helpful in capturing arrhythmias that have been otherwise difficult to record, in identifying rhythm disturbances or even normal rhythm in association with symptoms that may or may not be related to an arrhythmia. So I've been very impressed with those devices.
Excellent. Thank you very much. Looks like we have time for a few more questions here. And the next one is it normal at all for a heart to go into arrhythmia during physical exercise?
Well, it's not normal. What's normal is, as in the Michael Phelps example, for the heart to respond to a variety of factors that tell the heart, hey, we're exercising and we need to speed up the heart. We need to increase the contractility, increase the squeeze of the heart muscle, and shorten the time between upper and lower chamber contraction, really to optimize the function over that curve of output from 5 liters at rest to 30 liters at peak exertion. And so what you'll see is certain arrhythmias that are triggered by high levels of adrenaline, by increased stretch in the chamber because of increasing heart rate or volume status or whatever, or by electrolyte disturbances that happen as a result of electrolyte losses through sweat and insensible losses. You'll see arrhythmias that are triggered by those activities, and so atrial fibrillation can be triggered by those things. Less commonly atrial flutter, but atrial tachycardias, and then ventricular arrhythmias that can occur because a person has obstructive coronary disease and they can't provide enough blood flow down the coronaries to supply the heart muscle with blood and therefore with oxygen. That can create the substrate or the milieu for ventricular arrhythmia. So it's not normal, but it's common and it happens, and we commonly will evaluate that and manage appropriately depending on what the underlying rhythm problem is and what the cause may be.
Great, thank you very much for that. So this attendee writes, are patients coming in for procedures / echoes being tested for COVID-19?
They're being screened. So we have a series of questions that we ask to say, well, okay, who seems to be at higher risk? And if you're coming in for a procedure and you're going to spend the night, we're going to ask a lot of questions about have you been in contact with people at home? Have you been quarantined? Do you have a fever? Have you been in contact with anyone who's been sick? And then for people who need something done and seem to have higher risk, we'll get them to come for a COVID test, and based on the results of the testing, make a decision about the timing of proceeding as appropriate.
Thank you very much. This attendee writes that they have a pacemaker. Are there any unique risks for this person during the COVID-19 pandemic?
That's a great question. The answer is in part dependent upon why the person has a pacemaker, more so than the fact that they have one. So the people that have high risk for an adverse outcome or a difficult course with COVID-19 seem to be older and have high blood pressure and potentially in diabetes, chronic lung disease, and other things that you might predict would portend risk. And so some of those people also have a pacemaker. So it isn't the pacemaker that increased their risk, it's those underlying conditions. Now, there are other people who have a pacemaker for this or that reason that's separate from all of those things, and they just needed a pacemaker. But I wouldn't say that the presence of a pacemaker in and of itself changes a person's risk.
Excellent, thank you very much. Looks like we have quite a few questions that are sort of geared towards the same area, and I think this would be a good one to end off with here. But what are the latest breakthroughs in electrophysiology that give patients with AFib hope?
Wow, atrial fibrillation is a big topic, and I didn't touch on it so much today. But we're drowning in atrial fibrillation. I mean, we have a tremendous population of patients who are developing this arrhythmia, and we're committing tremendous resources to manage the risk that comes with atrial fibrillation and manage the symptoms. And so I think what you'll find is that for the population, we have a whole breadth of procedures and medications and devices that are available now, and some that are on the horizon to help with those problems. But each individual has a separate constellation of symptoms that we need to manage and risk that we need to manage. And so I think the best answer is to talk to your doctor about your specific constellation of symptoms and problems, and what is the most appropriate approach for that. I would also say that for people who feel like they're at the end of their rope with atrial fibrillation because everything that we have to offer has been done, then this new approach to pacing that we're using, where we're pacing the person's native conduction system, I think holds dramatic promise, because once the atrium will no longer behave, no matter what we do, the final approach to this problem has always been implant a pacemaker and ablate the person's intrinsic conduction system. And we always do that with some trepidation, because it's like we were trained and sworn to protect the conduction system. But once it becomes a liability for a person, you have to consider, well, can we do better than clobbering the person with pills to slow conduction through their conduction system? Now their conduction systems become a liability. So this idea that we can put a pacing wire right here into their intrinsic conduction system and then destroy the antenna up here and let the atrium fibrillate and then pace the ventricles, and the ventricles don't really know that that signal didn't come from the atrium, I think it holds a lot of promise. And we've seen early data that suggests that that'll be helpful. But in the big picture, you got to talk to your own doctor about what's the right approach for your situation. And then that approach needs to be tailored, and it needs to be revisited over time, because as things change, we do different things.
Excellent. Well,
Thank you. It's kind of a dodge, but it's also, I'm very hopeful about each patient with atrial fibrillation, because we have a breadth of things we can offer to help.
Absolutely. Thank you very much. Dr. Zakaib, we really appreciate your time and expertise. Is there any final remarks that you'd like to say before we have Chris come back up?
No, I think I just hope that everyone will be well and stay healthy and keep smiling.
Thank you.
Thank you. Thanks so much.
So I'm gonna go past all these very wonderful slides. Just one of the questions that I appreciated is just how to stay on top of what's happening. I don't think I mentioned it in the beginning, but our physicians at the Minneapolis Heart Institute, who partner with the foundation, publish over 200 peer-reviewed manuscripts annually. So if you're interested in looking at some of those, many are in the area of electrophysiology, you can visit our website and look at some of those publications. But I just want to thank everyone for joining us today and offer some ways you can stay connected with us via Facebook, Twitter, LinkedIn, Instagram. And we just thank you for your support in the many ways that can show up, and invite you to stay connected. We will do more of these On the Pulse educational offerings, and we look forward to having you join us in the future. So have a great day, and as Dr. Zakaib said, let's keep smiling. Thank you.